So I indeed will be talking about neuromuscular blockers or NMBAs and the backup plan and why it's considered the backup plan. So I can elaborate on that. So first of all, my disclosures, I have no financial disclosures, and I will discuss the off-label use of medications in my presentation, and you will see why I will be doing that. The objectives that I want to highlight for this presentation are just briefly, we will define ARDS or acute respiratory distress syndrome. We will recognize some common non-depolarizing NMBA blockers or non-depolarizing agents, because we have depolarizing and non-depolarizing. So I'll be focusing on the non-depolarizing. Then we'll discuss the current NMBA use in ARDS and even COVID-19. We'll recognize some of the shortages and what is being done during the COVID-19 pandemic and mitigation strategies that could be practiced by us all in our practice. I'm going to share an example where there's an established NMBA policy or procedure, or where one can be created for choosing an alternative agent, such as during a shortage. And that concept could be applied to many medications, but I'm focusing strictly on these NMBAs. And then I will also point out and recognize some of the common drug interactions that exist with the NMBA blockers. So first, I just want to start off with briefly defining ARDS. So if you can see here, this table is using the Berlin definition, which is the hallmark definition of ARDS. This is basically summarizing how ARDS is determined, diagnosed. As you can see, there's multiple components where there's timing, there's a chest imaging, origin of edema, but I'm focusing mostly on the oxygenation part. And this is where we are able to determine the levels of severity. So we have mild to moderate to even severe ARDS. And basically, if you look here in the highlighted region, the P to F ratio is basically what defines how severe ARDS is happening. So if you can see, severe ARDS is going to be a P to F ratio of less than or equal to 100 millimoles per mercury. So this is just a brief definition of that. And now I want to focus on some of the commonly used NMBA blockers in the critical care setting, ICU. So I've highlighted cisatracorium. The reason this is highlighted is because all of the references, all of the guidelines, when we need to use neuromuscular blockers, and specifically for ARDS management, all of the studies highlight the use of cisatracorium. And one of the reasons why is, if you can see in this table here, in this chart, it is not an aminosteroid non-depolarizing agent. So as you can see, the A represents aminosteroid component here. So it's one of the only few ones that is a non-aminosteroid neuromuscular blocker. So that basically means that it does not have any kind of corticosteroid adverse effects, because these other agents will have adverse effects similar to what steroids could cause. So that could vary from hyperglycemia to some cognitive impairment. So just to name a few, but cisatracorium is the most studied. It also is unique because it goes through the Hoffman elimination as far as PK, pharmacokinetic, pharmacodynamic properties. And Hoffman elimination means that it will have the least amount of adverse effects in terms of renal and hepatic impairment. As you can see, the other agents, and I'll be talking about other agents such as vecuronium and rocuronium, which are alternative agents, and we are only going to consider these agents if we do not have cisatracorium. So if you see the alternate agents, you can see that their time to blockade is similar, not that different. But when you see, and the dosing, you have bolus dosing, you have continuous infusion dosing, and we'll get into this. but focusing on the differences. As you can see, vecuronium has an active metabolite, so that if you have a patient that has a renal impairment, that will definitely accumulate, which will prolong the paralysis. As you can see, rocuronium does not have an active metabolite, but it is eliminated mostly by the hepatic metabolism. So it still can have, if you have liver issues, that can be prolonged as well. But Hoffman elimination is the more safer choice. So just to get into some of the evidence, so briefly, NMBAs in ARDS, these guidelines basically mention the practice of using NMBAs in critically ill patients. So they considered uh, in this reference that early initiation of a continuous neuroblocker infusion and a patient with a P to F ratio less than 150 would benefit from this. However, this evidence was weak. The quality was weak. The recommendation was also weak. And another thing to highlight from this reference is that they did mention that obese patients with a BMI greater than 30 should be dosed based on ideal or adjusted body weight. So that's something to highlight. The next study is a recent study. This was a Rose trial. This was released last year, obviously, and this was titled Early Neuromuscular Blockade in ARDS. But however, what this study found is that they compared two groups. One group was patients receiving NMBAs with deep sedation versus no NMBAs and light sedation. And what they found in this study, and this was something, something different than the usual standard and what has been normally recommended. So what they found is patients that were having an MBA blockade with deep sedation had more cardiac adverse events and muscle weakness in the NMBA group. And what they found is that the light sedation group targets may be more efficacious and safer than using early NMBA therapy with deep sedation. So this pretty much changed the way and kind of made people think, okay, are NMBAs beneficial or not in ARDS? So this trial, and this is more for moderate to severe ARDS, but this brought up that question. So it is debatable to use NMBAs in moderate to severe ARDS. Now we're going to get into COVID-19 in ARDS and a summary of the recommendations currently. So as you can see here, when COVID came around, obviously that changed the way we were going to use NMBAs. We were going to use them when we had to. So as you can see, what's highlighted here is that in COVID patients with moderate to severe ARDS, NMBA boluses are considered to be used to help with patients on a ventilator to make sure they're synchronized with the ventilation management. So boluses are recommended first. However, as you can see, just going down the line, if boluses aren't working, they've tried the higher PEEP option on the ventilator, they've prone the patient for hours and hours, then they may consider NMBA continuous infusion. And same thing also for rescue adjunct therapy. As you can see, it is also considered as an infusion if needed. So these recommendations also are there if needed. And this is why I was mentioning this is kind of like literally a backup plan if we need to use NMBAs. So now focusing on NMBAs in ARDS in COVID patients. So the recommendation and these guidelines obviously were released this year. So surviving sepsis, focusing on critically ill patients. So they recommended that for mechanically ventilated patients that we should use as needed intermittent boluses first over a continuous infusion. And that is the recommendation that you will see other societies and panels have been providing as well. However, if a patient has persistent ventilator dysynchrony, meaning they're not being synchronized with the ventilation. The patient is, they use the term fighting the ventilator. So you have to make sure the patient is synchronized. So if a patient needs deep sedation, if the patient needs to be receiving prone ventilation, so that means they're on their stomach, obviously, or persistently having high plateau pressures, then the recommendation is to suggest using a continuous NMB infusion for up to 48 hours. And this has been the standard recommendation for up to 48 hours. And however, but in real time, in practice, we can see this infusion go on for much longer than 48 hours. And both of these recommendations were also weak, just to uh, let you know. Next, the NIH guidelines referred the same thing, using intermittent boluses over a continuous infusion. This was also very similar to what we just saw, and this was again a moderate type of recommendation, and it was definitely an expert opinion. So very similar to what we just saw before. The next guidelines here at Johns Hopkins, we're also recommending the same, to consider using bolus dosing, intermittent dosing first, and if required, consider a infusion if necessary. However, we've also mentioned to use cisatracurium or vecuronium as possible options. Obviously, these recommendations were made. However, we can't predict drug shortages, and that is what leads to my next area of discussion, is the actual what happens if you have an MBA shortage during COVID-19. This can happen for various reasons. Obviously, there will be an increase in demand because patients may need to require it given their condition, given how sick they are, and we know how sick these patients can get. There could be manufacturing issues that could lead to shortages, quality issues, which can happen, production quotas. So this is why it's very important for managing supply, managing procurement, and also discontinuations. However, that does not apply to our area because obviously we are using these drugs and we need to. So some of the mitigation strategies that uh, seem to would benefit any institution are having a multidisciplinary team approach. So if we keep an eye on monitoring the demand and supply, using less of the drug, meaning considering using intermittent boluses first and over a continuous infusion, switching agents, uh, if possible, using vecuronium or rocuronium over cisatracurium, or or later, or if a patient is started on a cisatracurium infusion, maybe considering to switching that drug later on, but having a plan, and maybe even having some guidelines of reserving the cisatracurium, because it is evidence based in terms of all the literature that is there, that cisatracurium definitely is the drug of choice for paralytics. All the other two types obviously are off-label. So maybe if you consider reserving the cisatracurium when patients definitely do have renal or hepatic impairment, to avoid a prolonged paralysis. So that would definitely help those patients. And if short supply, obviously, then to consider the other options. But however, one thing to point out is use rocuronium over vecuronium, especially if there's significant renal impairment. And that was because what I mentioned earlier, because of the active metabolite. Also, what we can do is maybe provide some education and understanding of having a goal-directed use of NMBAs. So basically, our goal is to improve the P to F ratio and ventilator synchrony. And I just wanted to show you that for safety measures, the train of four is a method used by nursing to indicate the number of twitches that a patient can have while on a continuous infusion of neuromuscular blockers. Usually the goal is about 2. So this kind of approximates the number of receptors being blocked. So it is a safety mechanism that can be implied by nursing. So it is a combination of clinical assessment with safety measures to making sure we are using a goal-directed use. And the key obviously is to have patients paralyzed for the shortest amount of time. This is what I wanted to highlight. This is a list that is generated that shows the alternative agents to use to consider if there is a shortage of cisatricurium. So this is what we have on our policy, what we have on our guidelines, and what I have been advocating for uh, to use and to consider as backup, a backup plan. And C-Sat cream obviously is recommended, and as you can see, we have loading doses, but we're not usually using the loading dose. We'll focus on the intermittent dosing and the continuous infusion. So if we focus on intermittent dosing first, however, as we can see, and as I described earlier, that you may need to start a continuous infusion. So basically having a backup plan, having some kind of algorithm or chart that defines what to do in case we run out of cisatricurium, what to do next. And then we talked about um, uh, having maybe some pointers on how to also monitor these patients. So train of 4 is important for nursing to have. Um, Obviously, these patients most likely will be deeply sedated, but still having some kind of safety issue. And another thing I wanted to highlight is initiate eye lubricating drops and ointments for these patients. And the reason for this is because these patients, when they're paralyzed, they can have corneal abrasions. So making sure they have lubricating eye drops, ointments around the clock, and this can be given every few hours as needed. The last slide I wanted to focus on are the possible drug-drug interactions with NMBAs. And this just summarizes medications that can actually reduce the effects of NMBAs and medications that can actually prolong the effects of NMBAs. I won't go over all of them, but this is just a reference for you guys to have and to follow up on and to really look into if you do come across, and maybe uh, you will see this in practice. So these are my references.